Ivan, and a very good evening to all our viewers here on TV1. I'm Dr. Dilshan Fernando, and this is your weekly dose of wellness here on Healthline. Even though I say weekly, we haven't been able to come to you with Healthline for the past couple of weeks, and the reason being that we are battling a raging pandemic in our country and as well as globally. Things seem to be settling down a little bit, but by no means are we out of the woods. In this backdrop, we still don't want you to neglect your other aspects of your health. That is why we bring to you these kinds of programs, so that you have a better understanding of common medical conditions. Today, I thought of talking about a condition that gives you chronic pain and disability. I'm sure you would have heard your parents and your grandparents complaining about this condition day in and day out. And you might be wondering what this is. This condition is none other than the condition of osteoarthritis. And to talk about this matter, I have invited Dr. Parakrama Dharmaratne. He is a consultant orthopedic surgeon, and we will be talking in depth about osteoarthritis and focusing mainly on the knee joint. A very good evening to you, sir, and thank you very much for joining us here at Healthline.
Good evening.
So, first and foremost, tell us, what is arthritis?
Dilshan, arthritis is, as you said, it's a very common condition seen most commonly amongst elderly. So, the reason why one get arthritis is because it is mainly because of the wear and tear changes that occur as a patient or a person ages. But at the same time, there are several other reasons why one get arthritis, because of the trauma, because of inflammatory conditions. But all in all, mainly arthritis, if I define, that is wear and tear of cartilages, mainly in the weight bearing joints. So, that is when the patients come to us with symptoms. Namely, knee joint is the commonest joint that undergoes arthritic changes in Sri Lankan population. But yes, hip joints is also one of the main joints, but other joints like shoulder, wrist, ankle, arthritis in those joints are relatively rare.
So, basically it's a condition that causes disability due to wear and tear of the joints. So, how common is it in Sri Lanka as well as globally? Is it very common as an orthopedic surgeon in your practice? Do you see it very often?
It's widely prevalent, but then as I said, in Asian population we see more knee joint arthritis compared to Caucasian population. It is widely prevalent, but then it has many reasons as to one get arthritis, not only the age, weight, dietary habits, activity level. So, those are, it's all multifactorial why one get arthritis.
Now, when we talk about the Sri Lankan demographic, you say it's multifactorial. Is there a gender predisposition? Is it, now we see certain diseases males are more prone to it and certain diseases females. When we talk about osteoarthritis, is there a gender predisposition?
I would say yes, because now the patients that I see commonly in our clinics, in the government hospitals as well as in the private hospitals, show a premiale dominance in the condition, because most probably because of the hormonal imbalance which they come across after the menopause, and then weight gain during that period, and of course the activity level, and partly I believe that there is a role of genetics in our part of the world. Females have a very high chance of developing osteoarthritis compared to males.
So, females are more prone towards osteoarthritis, especially after menopause, and you mentioned about a genetic predisposition. So, does it mean that the condition runs in families? Does it mean that if your parents have it, you are more prone to get it as well?
Can do, because if your mother or grandmother had it, if you are a female, of course, you have a higher chance of developing osteoarthritis, because the cartilages which cover the ends of the joints are composed of a different type of hyaline cartilage. So, this hyaline cartilage has collagen in it. So, this collagen type, the resistance of collagen of one person may differ from another person. So, day to day activities, aging, and then your level of wear and tear can be more compared to another person in one who has genetic predisposition.
So, if I may reiterate what Dr. Dharmaratne said, the hyaline cartilage, basically the cushioning between the two joints, the substance that is made of collagen may differ from person to person, and depending on your genetic predisposition, you might be more prone to this type of disease. Why we talk about all this is so that you, our viewers, get a better understanding of what this is, but not to try and self-diagnose or medicate. So, you always have to keep that in mind. Moving on with the questions, sir. Now, you mentioned certain joints which are more prone to develop osteoarthritis. Can we elaborate a bit more on what these joints are and how this disease process occurs?
Yeah, as I said again, the knee joint has the highest predisposition to develop osteoarthritis in our population. The reason is, now let me show this to you, so then you will have a better understanding. So, that is the primary structure of a knee joint of anybody, and then inside here there is a nice cartilaginous covering, right, as well as on the other surface. So, this bone is called femur, this is tibia. On either side there is a beautiful cartilage covering, and in between there is another structure called meniscus, which is not depicted here, that also provides a cushioning effect. So, as we age, all these structures, just like our skin and the appearance fades off, the hair fall, our hair become grey, the cartilages also undergo wear and tear, dehydration related changes, and then it slowly break away and then expose the bones underneath. Cartilages inherently are painless, nerveless structures which gets its nutrition from the joint fluid, but bones underneath is full of nerve endings. The moment cartilage is worn off, or in areas where it's thinned down, it imposes pressure on the joints, on the bone, then patient is in a lot of pain.
So, now you spoke of pain. Now, we know that arthritis has a whole host of symptoms and signs, and there are certain stages of arthritis. Can you elaborate a bit more on what these stages and what kind of signs and symptoms develop as we progress?
Yeah, if I am asked by a lay person, I would say it has 3 stages: mild, moderate, severe. Mild is the lowest grade of arthritis, moderate is the middle grade, and the severe is the highest grade. So, it depends on person to person again. Mild arthritis, if I take an X-ray radiologically, I will see some narrowing of the joint space because of the wear and tear, and moderate, there is significant narrowing of the joint space in the knee or hip or wherever because of the wear and tear. Severe joint disease, you will see narrowed joint space plus obvious deformity, bowing of the legs, etc. From external appearance. So, that is how you basically categorize. That is the X-ray classification, but that does not mean that one has mild or moderate arthritis on the X-ray has less symptoms. Someone who is heavy, whose weight is more than average BMI, might have severe symptoms or very bad symptoms while having a mild to moderate arthritis, whereas someone has severe osteoarthritis on the X-ray may not have that much symptoms.
So, even though the symptoms may vary in degree, it is definitely necessary that you have to present to your doctor to get a proper assessment of what your pain is, the cause of your pain. So, moving on, so now if a patient comes to you, since you are focusing on the knee joint mainly, let's say a person presents to you with a pain in their knee, how would you go about assessing this patient, and what means would you employ to come to a definitive diagnosis?
All right. I would first, when a patient walks into my room, the external observation, the obesity, and the way the patient walks up to me. So, those are my primary observations, and then I take a detailed history from the patient, where when the disease process began, when the pain started, whether there was a obvious history of injury, or whether there is a family history of osteoarthritis, and whether there was an infection, whether there was a road traffic accident, etc. So, that is my history, and then I will ask about the pain history also, whether the pain is at rest, whether the pain is on activities, or whether the pain is while the patient is sleeping. So, those will give me a clue as to whether patient belongs to mild, moderate or severe category. So, that is the history taking part. Of course, whether there is swelling and whether there is redness, to exclude other conditions. Then I would go to do imaging, that is essentially X-ray imaging of front on and side on appearance of the knee joint. That will give me again a lead to diagnose what stage of arthritis the patient is in. And if I think internal structures like meniscus is damaged, then we might have to do images like MRI, but that is not very necessary to diagnose osteoarthritis.
Now, with these symptoms and signs, is it very specific to osteoarthritis, or are there any other alternative diagnosis you would consider before making a definitive diagnosis?
Yeah, that is a good question, because now my history, when I am taking the history from a patient, what I bear in my mind is that patient can have osteoarthritis or some form of inflammatory arthritis, namely things like rheumatoid arthritis, psoriatic arthritis, or arthritis related to ankylosing spondylitis, or conditions like gout. So, those also can cause arthritis. So, I have to ask about history related to those conditions also. So, while I bear that in my mind, I ask the history, and then by exclusion I come to the diagnosis of osteoarthritis.
Now, you mentioned about inflammatory arthritis. Can we very briefly describe to our viewers how would you differentiate, in a layperson's term, how would you differentiate between osteoarthritis or something that caused by wear and tear, as opposed to a condition like rheumatoid arthritis, an inflammatory condition?
Yeah, rheumatoid arthritis patients would primarily complain of, the joints affected are quite different. They do have arthritis in the metatarsophalangeal joints, these joints mainly. Of course, other joints can get involved like knees and hips, but then their symptoms are mainly in extremities, toes and hands. So, if their disease process started in those joints, and whether there is deformity in those joints, whether the patient has gone to a rheumatologist and had treatment for rheumatoid condition, then even though patient comes to me with a knee joint pain, I would always keep in mind that it could be rheumatoid disease, that is a inflammatory arthritis affecting the joint that the patient is complaining pain with.
Right. Now, we spoke about the symptoms, we spoke about imaging, X-rays, and possibly if required an MRI. So, once we diagnose this condition, there are various modalities of treatment. So, let us break it down for the benefit of our viewers. Now, the main symptom being the pain. So, let us talk about controlling the pain. What type of drugs can be given to take by mouth for these patients?
Dishan, medicine, even before I talk about medicine, once I have decided on the stage of arthritis, then whether it is mild, moderate or severe arthritis, once a patient has told what kind of pain, out of 10, I ask like where he rates or he or she rates the pain. So, if the pain scale out of 10 is pain rate is let us say if the patient says 3 out of 10, that means it is a bearable kind of pain. 5, yes, it is a significant pain. 5 and above, 6, 7, 8 out of 10 I would consider as a quite a significant pain which impair their day to day life. So, basic I like to start my medicines at the most basic level. So, starts from simple medications like paracetamol, which is taken on SOS whenever required basis, and then we might have to ask the patient to take paracetamol on regular basis, which is not harmful. And if it comes to a stage where paracetamol is not helpful, and if the patient has symptoms in spite being on paracetamol, then we have anti-inflammatory medications, non-steroidal anti-inflammatory medications, NSAIDs we call those. There are different brands. So, that is like stepwise manner, that is how I go. But certain people prescribe steroids also, which I generally do not advise, and if there are night symptoms, we can prescribe medications to relieve pain by giving some sedatives, etc. And of course, external devices like knee guards and application of ice, those therapeutic measures should also help.
So, you spoke about taking medication in a step up manner. You start with the most basic of paracetamol, then going on to non-steroidal anti-inflammatory drugs. So, we know that osteoarthritis is a very chronic condition, long term medication is required. So, when a person is on long term pain relief, especially medication like the NSAIDs or the non-steroidal anti-inflammatory drugs, what type of side effects can that occur?
One should be very careful when prescribing NSAIDs, especially in old people who are more susceptible to develop osteoarthritis, and they are also susceptible to develop renal ailments. But medicines like paracetamol, they are very safe unless you are allergic to those, so they can use it in the long run. But non-steroidal anti-inflammatory drugs have to be proven. Those are known medications which can cause chronic kidney ailments. So, when someone is prescribing those, you have to always ask whether the patient has a history of chronic kidney disease and whether the patient has been on medication for these kind of illnesses with NSAIDs for a long period of time. So, that history has to be taken and then taken into consideration when you start to prescribe. And what I normally do is I prescribe only for a short period of time, like I said, then rely on other measures like physical therapy, external bracing, and lifestyle modification, weight loss advice. So, that is the initial step of starting the medication.
So, that is one point that I want to reiterate in our program today, especially with regards to osteoarthritis and any other condition that may cause you chronic pain. You have to stick by the prescription given by your doctor. You should not continue pain medication thinking it will give me relief, because it can result in conditions like chronic kidney disease. So, once your prescription is done, you have to return back to your medical practitioner and check with he or she whether you should continue this medication, especially if you are trying to self-medicate. This is a very important point. So, moving on with the modalities of treatment, sir. Now, we have seen certain injections, especially intra-articular injections that is being injected to the joints. What are these and what kind of effect does it have on these joints?
Okay, now we are in, let us say, step 3 of pain management. First step, we started with paracetamol, external bracing, then NSAIDs and paracetamol with external bracing, lifestyle modification, and then comes injections. So, commonly used injection is called it's a steroid injection. There are different trade names for those. The steroids mixed with local anesthetic is a recommended mode of treatment for early osteoarthritis or even moderate osteoarthritis. What it does is, steroids are it's safe to use in joints, unlike intravenous steroids and orally taken steroids. So it reduces the inflammation at the local site. So reason why one get pain primarily is the inflammation. If something goes into the joint and reduces the inflammation, it automatically reduces the pain. So that effect of steroid injection can last for months to years in certain people. So that's a good safe mode of treatment when it comes to osteoarthritis.
So basically, we inject a steroid into the joint, and that reduces the inflammation, and in turn it reduces the pain. Now, in the recent past, we have seen injections of PRP, or plasma rich protein as they call it. What is the role of plasma rich protein in osteoarthritis?
Dishan, platelet-rich plasma, it is correctly named as platelet-rich plasma. Platelets are a component which is known to have healing potential. So from our own blood, we take about 10 milliliters of blood volume and then spin it in a machine and then get a concentrate of platelet-rich plasma, and then we inject that into the joint. Here what we expect is the platelet-rich plasma, the platelet component of it, to heal the damaged bones, or at least to form a layer around the damaged areas. But then there is a new medicine called HAPRP. So that is something that I use regularly, hyaluronic acid PRP. Hyaluronic acid is a naturally occurring lubricant which is present in our joint fluid, and it is made outside synthetic hyaluronic acid, and that comes in a vial, and that can be mixed with our platelet rich plasma and inject into joints. That has superior effects compared to plain platelet rich plasma, according to my observation.
Now, we spoke about pain relief, oral medication, intraarticular injections. I think we missed out on the middle layer, the lifestyle modifications. So what type of lifestyle modifications can one achieve to reduce these symptoms and signs?
Yeah, most of the younger people and middle-aged people, they wish to go for a run, go for a jog. So, but then in the long run, I would say that's not all that great, because so it's a impact sport. So after a certain age group, our cartilages are not able to withstand that stress. So though we enjoy running on a hard surface, roads, etc., it damages the cartilages. So I would like to advise, not totally against it. There are other modes of exercises. Of course, you can go for a walk, a very light jog, wearing a good pair of shoes which provides cushioning effect, and then resort to other exercise modalities to keep fit. And then most importantly, weight reduction methods. I would say a lot of people try to reduce weight by running and jogging and then exerting themselves, and that increases osteoarthritis. So the pain is more. So more they run, more they exercise, it increases osteoarthritis. But then 60% of your weight is from your diet. So you should try to go on a regular strict diet pattern and reduce weight by dieting, rather than trying to reduce all the weight by exercise. But of course, you should do exercise, but you have to be watchful about what you eat.
So now you said about this jogging and running. Is it does it hold true for those who haven't been diagnosed with osteoarthritis as well, or for the osteoarthritic patients?
It's for everyone.
For everyone.
It's for everyone. But then I'm not telling people not to do that. But it should be with caution, and then try to use a softer surface to run. If you enjoy running, then have intervals, like you don't run morning, evening, next day morning. So tissues need time to heal. So you have to have some interval for the tissues to heal, and then you continue with your leisure activities.
Now, especially with the younger population, we see a bone of contention about running on these treadmills, especially on incline. What is your advice about using treadmills on a daily basis?
It's the same advice that I would give. I gave before. Treadmill is nothing different to running on a hard surface, but it makes you feel good. But then you have to bear in mind that you are heading for some osteoarthritis in the future. But then there is another way of looking at this. So there are things that you can do when you are a certain age. You can't run in a treadmill when you are 70. So if you enjoy running on a treadmill, so you can do it, but with caution, and then prevent or delay the process of osteoarthritis from happening.
Now, when talking about these lifestyle modifications, you spoke about the weight and the diet. So obviously, by controlling your diet, you can cut down on the weight, and that will definitely have beneficial effect on the joints. But are there certain types of food that can predispose towards or increase this osteoarthritic condition?
If you ask me that, I would first say excessive consumption of carbohydrates and sugars, which increases weight. So that is the main problem on a person who is not genetically predisposed, on a person who is not really active. If that person gets osteoarthritis, that's mainly because of the weight. And rest of the food, of course, any healthy diet should not matter. So weight is the main reason, but then pro-inflammatory food, so those things also can matter. But then what I would say is carbs and sugar, by increasing the weight, play a major role in increasing the prevalence of osteoarthritis.
And on the flip side, are there any types of food that can have a protective effect?
Yeah, but if you ask that question from me, what I would say is the generally accepted healthy food like fish, lean meat, and things like cod liver oil or fish oil, those should give you a certain amount of protection, but those are not absolute protective measures.
Now, talking about food, let's move on to supplements. We see that certain supplements are given to patients who have osteoarthritis. What are these supplements and what kind of effect does it have?
That's a very difficult question to answer, because I feel most of these supplements are a sort of I would say it's a global business kind of thing. I don't generally promote any supplements for patients who have osteoarthritis. This is my personal opinion, I would like to go with basic medications, basic lifestyle modifications, and manage the pain.
Now, we spoke of oral pain medications, intraarticular injections, lifestyle modifications. If all that has failed, what would be the indications to go in for a surgical intervention?
Essentially, the pain, right? If one has pain, in spite having done all of these treatment, and if one has severe deformity and the pain is, let's say, 6 to 7 to 8 out of 10 day in day out, that is that's a very good indication to go in for a surgery. So when you ask about surgery, we start with simple surgeries like arthroscopic surgeries. So we can do a camera assisted joint washout, which again doesn't have a long term benefit. But then when we talk about definitive measures, there are certain types of osteotomies, that is to divide the bone at certain ends, especially in a weight bearing area where there is a lot of wear and tear, and then we shift the forces to the other side. So that is called an osteotomy. So those are the early stage surgeries. Then of course, if it doesn't work, we'll have to go for a partial or total knee joint replacement.
So when we talk about knee joint replacement for a lay person, it might sound a bit magical, or it might sound like something to do, I mean, you become something bionic. So if you can explain what this knee replacement is, do we entirely take off the knee joint and replace it with a prosthesis, or how does it happen? Can you elaborate a bit more on what this knee replacement is?
All right. So let me show this to you. This is a model of knee joint replaced tibia and joint replaced femur, right? So as you said, yeah, we remove the entire knee joint. I would agree with you, because we cut this surface entirely off, which was a pain generating surface, and we cut this surface off entirely. That again was a pain generating surface, and then we replace with this special metal devices, which is made out of a special metal called cobalt chrome, and that's also the tibial plate is also cobalt chrome. And then what is in the middle, the white structure there, is that's made out of a material called highly cross-linked polyethylene, so which has a very high wear and tear resistance, and then these knee joints can last for 15 to 20 years on an average individual.
So if a person is indeed going in for a surgery like total knee replacement, our viewers would like to know what kind of pre-operative preparation, then intraoperatively during the surgery, what can they expect, and most importantly post-operatively, what kind of recovery period they will have and what kind of rehabilitation process they will have to undergo. So can you elaborate on this process?
Yeah. Pre-operatively, of course, the patient has to make sure that he or she wants a knee joint replacement. It should not be doctor's suggestion or the relative's suggestion, because it's a major undertaking, and then so that decision making should be patient's, and then patient has to know there are certain complications with related to these major surgeries: bleeding into joint, infections, and persistent pain which can be there in certain people. So those have to be understood. And intraoperatively, of course, in a good theatre setup, infection chances are very low. And then post-operative pain, we have a very good cocktail of analgesics, but then still there will be certain amount of pain that patient has to expect. And post-operatively, there is no like huge hospital stay, I mean time period. We just keep the patient, I personally keep only for a day or two in a hospital, and then there is no waiting time before you walk. Let's say about 8 to 10 hours after the surgery, you are walking, you are on your feet, and a physiotherapist is assisting you to walk. And then after 2 days you go home, and every day or every other day physical therapy, and then you are not in one place, you are mobile. And then you should wear, or we always ask them to wear, deep vein thrombosis prevention stockings, and then we will take physical measures to prevent deep vein thrombosis formation. And then the rehabilitation after about 2 weeks, when the pain goes down, it becomes very easy. They tend to walk on their own, maybe with a single crutch, and then climbing stairs is possible after about 2 weeks, and then the stitches come off or the plasters come off in about 2 weeks time, and then by about 1.5 to 2 months you're basically completely cured, and then I would say the patient has had a new leash of life.
So basically, if I reiterate, maybe 2 to 3 days of hospital stay, and after about maybe 1.5 months back to the regular usual day-to-day lifestyle. So you mentioned a couple of complications that might occur if patients tend to neglect these conditions and if they don't get timely medical intervention. Can you elaborate a bit more? What can happen if a patient doesn't present to a qualified medical practitioner and they tend to neglect this condition?
Dishan, I would say it's a tricky question, because now when a person, like lots of people go to general practitioners and then they treat them with a lot of anti-inflammatory analgesics, and then they do not refer the patient on time to get a surgery done when the time is right, when the right time comes. So they come to us with a severely deformed knee joints, and the correction of those are very difficult, technically difficult, and then when these average kind of regular prostheses cannot be used on them, we will have to use special augments, and then more expensive implants have to go in, and late diagnosis and wrong diagnosis is another problem. So it's always good to go to a qualified orthopedic person to get opinion when you have joint pains.
So with the time constraints we have for our program, we are coming towards the end of this edition of Healthline. Before we wind up, sir, what would be your message to our viewers with regards to arthritis, osteoarthritis in particular?
My message would be, it is not something uncommon. It is common to all of us. All of us humans have a very high chance of developing osteoarthritis. So we will have to understand that it is a normal phenomenon, and then there are ways to delay the process of us needing a surgery. So if you have understood that, and if you go to a medical practitioner, an orthopedic surgeon on time, and then we can delay the process of needing a joint replacement, or in some people we can even prevent one from needing a major knee replacement.
So there you have it. Osteoarthritis is a very common condition, but a condition that can certainly be treated, and definitely we want our viewers to seek properly qualified medical practitioners' help without trying to self-medicate, because if you tend to self-medicate for a long period, you tend to develop more complications. So with that, I thank Dr. Parakrama Dharmaratne very much for joining us with this episode of Healthline. Thank you very much, sir.
Thank you for having me.
And before we wind up, I want to reiterate once again, we are out there in the front lines battling a pandemic, and we are not out of the woods yet. Get your vaccinations, wear your face mask, do proper hand washing, follow the respiratory etiquette for yourself, for your loved ones, and for everyone's sake. And with that message, I take your leave from this episode of Healthline. Until I meet you again next week with your weekly dose of wellness, this is me, Dr. Dilshan Fernando, wishing all our viewers Aibowan.